Good evening. This is Dr. John Bennett broadcasting from Bharatnagar, Nepal at the Nobel Medical College for the ACNS Neurosurgery Student Society. This week we have the honor of having Francesca Pazlaru. She's a medical student from Romania and also the president of the Walter Dandy Society of Romania. And we're joined also by a friend of Francesca, Elena. Elena, could you please introduce yourself? Tell us where you go to school, etc., etc.
Hello, everybody. My name is Elena Neștian. I'm a fourth-year medical student. And as my colleagues, I'm very interested in neurosurgery. I've been watching the neurosurgical TV, actually, and I find all these presentations really interesting and very useful for us, the students, because it helps us learn new stuff in a very interactive way and also get in touch with people and professionals all around the world. So thank you, Dr. Bennett, for offering us such a chance.
Okay, welcome, Elena. Your dream is coming true. Okay, Francesca, welcome, and it's all yours.
Okay, hello everybody, I'm Francesca. I'm a sixth-year medical student from Bucharest, Romania, and actually I'm the former president of the Walter Dandy Neurosurgical Club, and Elena is our vice president this year. I'm glad to be here again, and I hope this presentation will seem interesting enough for medical students. And I think we could begin. Let me see. Is this working?
No. Not yet, Francesca. I'm sorry. I was.
Now it's fine. Why we can't see it? I don't know how to make it larger. No, I don't think this is okay. Let me try again. Do you see the slides?
No, we just see you and your beautiful library.
I'm sorry, not yet.
I don't know how to make it work.
Don't worry, you'll get it.
Like this? Is this working?
Not quite. I can tell you're not screen sharing because you're not clicking on the screen share on the left side, the screen share button.
Share your screen. Oh, okay. Now. Okay, this does not look good.
You picked the wrong screen. Hey, excellent. Oh, I don't know what happened there.
Okay, I stopped it and try again.
Okay.
How do I pick another screen?
Yeah, I think you picked the, well, you know how to do it. You did it before. Just.
Yeah, but not on this laptop, actually. Yeah.
Yeah, the way I do it, Francesca, I first put the power, I get off the hangout. There you go. You got it. You got it.
Yeah, I found it. Okay. Now it's working?
Yes, yes.
Yes. So I'm going to talk about changes of the age pattern in glioma patients. And why is this happening again? Oh. Okay. Now.
Okay, just click on the screen. Usually changes
okay.
the slide.
So gliomas comprise of a group of primary central nervous system neoplasms with characteristics of neuroglial cells. This is why we call them gliomas. They are derived from neuroglial cells. like astrocytes, oligodendrocytes, and they express varying degrees of aggressiveness. The first things the medical student needs to know about these tumors is that they are primary brain tumors or spinal cord. This means they are not outside the brain, they are inside the brain, and they invade the structures that are found in there. And historically, the slower growing lesions corresponding to the World Health Organization grades 1 and 2 have been commonly referred to as low-grade gliomas, while the most rapidly progressive tumors, the grades 3 and 4, have been called high-grade gliomas. And also, the low-grade gliomas have mistakenly been called benign tumors. These tumors are not benign, only they have a lower degree of aggressiveness, but after resection, these tumors do recur in maybe 10, 15 years, and when they recur, they usually become a higher grade tumor. And this is actually an issue regarding the treatment, because neurosurgeons don't know if we should use from the beginning all the treatment strategies that are available to us, like resection, of course, and chemotherapy with temozolomide and radiotherapy, or maybe to keep these adjuvant therapies for the recurrence, because it's more difficult to operate. It's already difficult to operate on a high-grade tumor, and it's more difficult if that brain has already been irradiated. That's one issue. And this is the World Health Organization classification system I was talking about. I'll repeat, the grade 1 and 2 are low-grade gliomas, classically, and 3 and 4, with 4 comprising of multiforme glioblastoma, which is the most aggressive type of brain tumor that actually exists. And this is, just to have an idea, an image of a pilocytic astrocytoma, who grade 1 tumor in the cerebellum. You can see here. You see the cystic component and the fact that this tumor does not infiltrate as much tissue as the other one. This is a typical aspect of a butterfly glioblastoma. This happens when the tumor starts in one hemisphere and then invades the corpus callosum and becomes bihemispheric, like in this. And I want to talk about the experience of the neurosurgical department where I go and study. This is the 3rd neurosurgical department of Pacta Arseni Emergency Hospital in Bucharest, Romania. And they had 2021 patients, 221 patients operated for glioma between 2010 and 2016. And in this group, actually 174 patients, this means 79%, had a glioblastoma. So 79% of the glioma patients had a very aggressive type of brain tumor. And the mean age for glioblastoma patients was 59 years old, and the low-grade glioma patients had a mean age of 38 years old. It's already known that low-grade gliomas tend to appear in younger people than higher-grade gliomas. Okay, and I wanted to see if the age at diagnosis and the minimum age changed in these 6 years from where I got my data. It does not seem to change when it comes to low-grade gliomas. You can see that it's quite linear, and the minimum age seems to be this heterogeneous, but you have to keep in mind that this is an adult department actually, so we don't really see many children, and the pilocytic astrocytoma is known to appear in younger ages, mainly in children. So this would be a problem. But in glioblastoma, it seems to be an increase diagnosis. You can see here from 57 in 2010 to 61 in 2016. But I observed that the minimum age at diagnosis seems to be decreasing. It was over 30 years old until 2014 and under 30 years old in the last years, with 24 on 2015, 26 on 2016, and I did not use that data, but until now it's 27 in 2017. So I thought, what could this mean, and if it has any impact on how we should treat our patients. And what we should know about glioblastoma multiforme, I already said, it's the deadliest form of brain tumor, and it has more than 90% at 5 years, 90% mortality at 5 years. And it can arise either as primary glioblastoma or it can derive from a previous lower grade glioma, as I said. And current treatment standard is as maximal resection as possible, followed by radiation therapy and chemotherapy. But this raises actually an issue, because this is how the tumor looks like. And only this part in the middle is what we see on the MRI. So we do not actually know how extensive this brain tumor is. And in the brain, you can't really resect that much, because you will hit an eloquent area at some point. So you do as the best resection you can do, but probably there are still some glioblastoma cells left somewhere in the parenchyma, because it invades so much. So these glioblastoma cells will start to multiply, and they will the tumor will recur, and fast. And in our series of 147 glioblastoma patients, 135, this means 92%, had a primary glioblastoma, and only 20 patients, this means 8%, had the secondary glioblastoma derived from a previous lower grade glioma. One has to keep in mind that the recurrence can also be a third grade glioma, like an anaplastic astrocytoma, and I did not took into account these cases. And average age at diagnosis for primary glioblastoma patients was 60 years old, and for secondary glioblastoma patients was 53 years old. And this could be explained by the fact that I already said that low-grade tumors, those that recur and become secondary glioblastomas, tend to occur at younger ages. So maybe this is why the secondary glioblastoma appears earlier than the primary one. That would be another idea. So what could this data mean? I said that mean age at diagnosis for glioblastoma patients seems to be increasing. So older patients with more comorbidities are suffering from a very aggressive brain tumor. And you have to keep in mind that we as doctors are not only interested in the overall survival of the patient to prolong the survival, also we have to think about the quality of life, and using aggressive therapies on older patients may be or might not be the best thing for them. And this is to be discussed later. And also, younger stage at diagnosis seems to be decreasing, and this means younger patients. Actually, the reason I started this presentation was that in 2016, I think I met a patient my age with a glioblastoma, and this quite kind of hit me. And this means that younger patients are suffering from a still deadly condition, because we still don't know how to treat these patients. We do not have a curative treatment, and the current standard is only to try to prolong the survival, which is still low. I think in the most optimistic studies, it's 15 months now. So, the first issue of the elderly glioblastoma patients have been approached in the literature, like a lot. I found 92 articles published only in the last 5 years regarding the management of elderly patients with glioblastoma. And what I understood is that the mean age at diagnosis seems to be slowly increasing, and this is consistent with what we found, and that age remains the most powerful prognostic factors among glioblastoma patients. And this could be first because these patients have a lower performance status score to begin with, have many other diseases associated like diabetes or hypertension and so on. And also because doctors are not as keen on using the same type of aggressive treatment as if in the cases of younger patients. So the reduced use of therapies is another problem. And some studies like this one, the lower one, says that there is an underutilization of radiation therapy in patients with glioblastoma, one of the adjuvant therapies. But some trials have demonstrated that it actually has survival benefit in patients with glioblastoma, and maybe the same kind of aggressive treatment should be used at least in patients who have performance status score good. And I said that glioblastoma has a median survival of 12.6 months in this study, and this is attributed to the unique treatment limitations such as high average age of onset, which tends to become higher, tumor location, the fact maybe that this tumor invades a lot, and it will catch some eloquent area or structure, and the fact that we still don't really know much about the tumor pathophysiology. And now the resection techniques have improved. Or in other departments, they use neuronavigation or maybe awake surgery for glioma tumors in order to extend the resection, but gross total resection is still not really possible. Chemotherapy strategies also have changed, even though in Romania, at least we only use typically temozolomide, and radiation therapy has improved as well. But these improvements have not translated to marked increase in patient survival. So that's about the older patients. And about the younger patients, there have been 1,135 articles published on novel therapies for glioblastoma in the last 5 years. And there have been developed things like monoclonal antibodies like bevacizumab. I think there's a clinical trial happening even in Bucharest now with quite good results, but not good enough maybe. There have been developed oncolytic viruses. I think fibroblasts have also been used to modify them to target glioblastoma cells, and many other therapies. They try to improve the patient's immune system for the body to attack these cells, but until now is nothing used on a large scale. So those patients I was talking about, those under 30 years old, and all of them actually really need a good treatment strategy and fast, because they don't have much time. So, in conclusion, in our group of patients, glioblastoma comprised 79% of the glial cell tumors. This means that for a neurosurgeon or a future neurosurgeon, that most of too many of the tumors that you will operate are not curable. So you do not help that patient enough. And the mean age at diagnosis seems to be increasing, meaning that older patients with more comorbidities need a very aggressive treatment in order to have a prolonged survival, and may or may not survive the treatment maybe. And younger stage at diagnosis seems to be decreasing. This means that younger patients, maybe our age, start suffering from a deadly disease and are in desperate need for new and efficient treatment strategies. This is what I would like to point out. So thank you for listening, and I want to show our group in Bucharest. This is a photo from last year. I'm very grateful to have the best colleagues in the world, and I really hope that maybe we could make a difference, and maybe many more groups would start appearing in other countries. It would be great if we could communicate between us. Thank you.
Excellent, Francesca. It's amazing a student can give such a comprehensive presentation. And I congratulate both you guys on getting an early start on your neurosurgical career. That's the kind of presentation you see at conferences. Very, very, very comprehensive. Okay, Elena, do you have any comments or something to say to Francesca?
Yes, first of all, I would like to congratulate her for her work. So many articles. It must have taken you so much time doing all of the reading and then gathering the data. Regarding the glioblastoma, I think it's a really real challenge, and in matters of diagnosis and treatment. And I would like to point out that one neuroradiologist pointed out at a conference that we still have a problem about detecting the early stages of glioblastoma. They have a special metabolism, and they only appear on imaging studies quite late, like after a year or two. So when we notice that the patient has a problem, the tumor has already diffused into the brain tissue and maybe will come out as a big aggressive tumor in the next month.
Well, you know, it is such a grim diagnosis, and like you both said, you know, treatment and survival not increased noticeably. Like in many forms of cancer, with the advances in medicine in the last 10, 15 years, there's been a decrease in all types of cancers. But this is unfortunately one of those cancers that's a very grim diagnosis. And the only way we can start to make headway is by early diagnosis. I guess to increase slightly the increased survivability. But hopefully things will get better. I know that really surgery, chemotherapy, radiation, to use the survival 95%. I think he said that 95%. That's a 2-year survival, right, Francesca, or is that 5-year? Oh,
no, I said 5-year survival, and median survival is about a year, 12.9 months.
Yeah, that's probably one of the most lethal forms of cancer. Now, turning to you individually, Francesca and Elena, you've decided, or probably make a pretty firm decision on the neurosurgical career. How about you, Elena? When did you first know that you wanted to go in neurosurgery?
It's a very interesting story. I was in the first year of medical school, and I went during summer on my practice program, and I managed to sign in on an orthopedics program. It was a European project which involved 3 weeks of medical practice on an orthopedics ward, but the orthopedics and the neurosurgery shared the same pre-operative rooms. So I had the chance to meet neurosurgeons, and I talked to the head of the department and was very, very kind, and he welcomed to his department, and I spent the next 3 weeks with his colleagues, and they taught me really useful stuff. And that's when I found out that I wanted to be a neurosurgeon, because what I saw that summer impressed me, really impressed me.
Very good. How about you, Francesca? How about you? Hope you're on mute there, Francesca. Just
Yeah.
okay.
I don't know. I think I was always interested in the brain. It's the only organ we don't know much about. And in my first year as well, I met the head of the neurosurgical department, where I still go and study. And he told me that if I want to become a neurosurgeon, I should come during the holidays in his department, but I can't just come for 2 or 3 weeks, as we have the mandatory summer practice. If I come, I have to stay the whole holiday, because there is a lot of work to do. And so I went, and I entered the operating room, and I think I never left.
I think it's marvelous. There's a lot of neurosurgical groups around the world, neurosurgical students. And we've met other students from other parts of the world. I think it's amazing. I can't remember that happening when I was a medical student, but I'm glad to see it. Okay, thank you very much, Francesca and Elena. Next presentation in a half an hour with Slaven. He's going to give a presentation on Albert Wotan's neuroanatomy series. So you're welcome to come back. And I'll send you a link. You can join us if you want. I'll send you the link, Francesca. Okay. Thank you.